A very warm welcome to all the delegates who are here to attend the next session, which is dedicated to Bihar Ophthalmological Society. May I request our past president, Dr. Milind sir, to please come on the chair. May I request our former secretary, Dr. Vibhuti Prasad Sinha, and head of the Department of AIOS2025-GP89 to please come on the chair in the front. May I request our Vice President, Dr. Nagendra Prasad sir, to please join us on the chair. May I request my Treasurer, Dr. Nilesh Mohan, Professor Nilesh Mohan, to please join us on the chair. Do we have Dr. Subhash Prasad here? May I request the first speaker, Dr. Rakhi Kusumesh, to please make her presentation on miltefosine, healing agent or hidden threat. May I request Dr. Shalabh Sinha is here?
Yes, he's here.
Shalabh? He is supposed to be on the chair. Dr. Shivani, can I please request you to come?
Good morning, everyone. I am Dr. Rakhi, Professor RIO IJMS. So, first of all, I would like to thank Office Bearer of Bihar Ophthalmology Society for giving me this opportunity. I am presenting an interesting and concerning topic, that is miltefosine, healing agent or hidden threat. I have no financial interest in the subject matter. So let me begin my presentation by introducing this drug, miltefosine, which was originally developed as anti-cancer drug, and it was first oral drug approved for visceral leishmaniasis, that is Kala-Azar. And later it was explored as an anti-amoebic agent because of its anti-parasitic activity, including acanthamoeba keratitis. And in 2016, it has got the status of orphan drug designation by FDA for acanthamoeba keratitis. So recently, this miltefosine has gained a lot of attention as a potential treatment option in refractory acanthamoeba keratitis, where the standard treatment fails. And what is special about it? That it acts both against trophozoite and the cyst. Now, the role of this drug miltefosine is well established in Kala-Azar and its sequelae, that is post-Kala-Azar dermal leishmaniasis, and it works well as oral anti-parasitic agent. And this is why the people have started thinking of its use in acanthamoeba keratitis also. So we know that it's a healing agent for leishmaniasis and it's a potential agent for acanthamoeba keratitis. But we should know it whether it is completely safe for the patient or not. So let us share some the cases which shows the threat of this drug. So I'm sharing few cases with you. Case 1, a 31-year-old male who had been taking miltefosine drug for 48 days for post-Kala-Azar dermal leishmaniasis. And he presented to us with this kind of picture where both eye had significant annular deep stromal infiltrate, which was rapidly progressing. And when he presented to us, we sent the sample for microbiological examination. Within 24 to 48 hours, the whole cornea was involved with central thinning of the cornea. And we had to do keratoplasty in the right eye. And when the test came negative, we started the oral and topical steroid in these cases, and patient responded very well with these drops and oral drugs. Next case, again with the similar presentation, bilateral keratitis, 45-year-old male, and he was taking meltefosin for 35 days. Here also we got the similar picture, ulcerative keratitis, 360-degree involvement, full thickness involvement, rapidly progressing, involving central cornea very soon. So we had to perform keratoplasty in right eye, and again we started the oral steroid and topical steroid under antibacterial cover. And patient responded very well and gained 6/9 vision in the left eye. Similarly, we got 3 or 4 cases of unilateral keratitis, and these patients were intelligent. They stopped the drug immediately when they feel something bad in their eyes, and so the lesion was not of severe grade. So when they presented to us, they were unilateral involvement and the annular infiltrate, but far from the limbus. They have not involved the exactly the 360 degree of limbus. We got similar cases again, and all cases responded well to the topical steroid. We didn't have to start any oral treatment in these patients. Now, after observing so many cases with consistent pattern of keratitis and a typical clinical course, we termed this entity as a meltefosin related keratitis and divided into 2 stages, early stage and advanced stage. In early stage, patient comes with unilateral presentation, and there is a gap between the infiltrate and the limbus. That means lucid interval is present in between these lesions. And in advanced stages, the whole cornea is involved, including center as well as the whole circumference. So in unilateral cases, we don't have to give oral steroid, just topical steroid. Patient responds very well. And in advanced stages, oral therapy is also necessary to get good results. So management of these cases, just to stop meltefosin immediately, exclude infectious etiology if possible, initiate early and intense anti-inflammatory therapy immediately, and defer any surgical intervention if possible. There are 2 or 3 more cases reported from India and Bangladesh, but they term differently to each lesion. And in 2021, we named meltefosin-related keratitis with ring ulcerative keratitis. And this case was published in British Journal of Ophthalmology in 2021. And then after 2 months of this publication, WHO took it very seriously, and they mentioned this complication on their webpage. After that, they form a disciplinary technical group, and they publish a complete SOP to minimize the risk of this with this drug. Again, this was the hidden threat of meltefosin associated with the Kala Azar. Now we are ophthalmologists. We are more interested in meltefosin as a hope for refractory acanthamoeba keratitis cases. So number of literature have shown that this is efficacious drug in cases of acanthamoeba, but there are some documents which shows that it has side effects also. So there is a pilot study done in LV Prasad Eye Institute, and it shows that when they started topical meltefosin as a monotherapy in 5 patients or acanthamoeba keratitis, the all patient worsened, and they required therapeutic PK at that time, and 1 case required evisceration also. Again, in another study where the systemic meltefosin was started, and they found in 2 of their cases that there was a rapid and destructive inflammatory reaction in the AC along with the cornea, and because of the increased immunological activity. So we should be very careful while advising the meltefosin in these cases. So to conclude, meltefosin is definitely a double-edged sword. It has a healing potential in both leishmaniasis and as a potential agent in acanthamoeba keratitis. But there are reports which shows that there could be worsening with the use of these drugs. So we should become very careful while prescribing these drugs, and we should have a very close monitoring on these patients. Thank you. Any questions?
समय कहाँ है? as we are running behind time, so we'll proceed with the next talk by Dr. Nilesh Mohan sir on therapeutic penetrating keratoplasty outcomes in a major Eastern Indian healthcare center. Sir is a professor at AIOS2025-GP89 and heads the cornea and refractive services there.
Good afternoon, everyone. At the outset, I would really thank the scientific committee of AIOC and APO and the chief instructor for giving me the opportunity to be here. Therapeutic penetrating keratoplasty basically has got different outcomes. So we had observed the outcome of first 100 keratoplasties at our center. As we all know, corneal blindness is an important cause of loss of vision. And as per the NPCB estimates, around 120,000 corneal blind persons in India, adding 25 to 30,000 every year. The core study suggests that the infectious keratitis is a very important cause of corneal blindness and a cause of morbidity in Indian population. So one of the landmark studies of South India has recognized corneal ulcer as a silent epidemic in this zone. So progressive corneal ulcers not responding to medications often definitively need the treatment of therapeutic penetrating keratoplasty. The post-operative outcomes in these type of cases have been observed in different studies in relation to infection eradication, the visual acuity achieved, the history of associated trauma or the use of any traditional medications, or a pre-existing scleral involvement, or having coexisting diseases. So we at our place analyzed the clinical outcome of first 100 therapeutic penetrating keratoplasty cases. A retrospective analysis was done for TPKs for non-healing keratitis with or without perforation with a minimum 1 year of follow-up, and we excluded patients with vitreous exudates. Medical records of these patients were done between October 2014 to December 2017, and the primary treatment of these patients were according to the severity of the presentation, and primary microbial evaluation was performed at the time of presentation and was repeated after a week in cases of non-responding ulcers. Initial antimicrobial treatment was modified as per the culture sensitivity report and clinical response to the treatment. Posterior evaluation was done as done routinely in these cases. TPK was performed after the failed initial management in non-responding progressive ulcers, ulcers having desmetocele, or perforated corneal ulcers. The donor cornea utilized in surgery was of therapeutic grade, and the standard average size used was 9 millimeter. Primary lens removal was done in cases where anterior capsule was involved, and donor corneal button was larger than the graft size by 0.5 millimeter and was standardly secured by 10-0 MFN suture. Post-operative medications included antimicrobials, cycloplegic agents, intraocular lowering agents, and lubricating drops. Post-TPK glaucoma was considered as an IOP higher than 21 millimeters of mercury or digitally raised IOP where the IOP couldn't be measured. Success of surgery was measured as a measure of infection eradication and maintenance of the globe integrity. Other factors which were considered were the need of repeat surgery, the IOP control, and graft clarity. Now, these cases of TPK were followed up for a period of 1 year. All the ulcers included in our study were graded as per the classification. 15 cases presented with corneal perforation larger than 3 millimeter in size. 22 cases had desmetocele at the time of presentation, and scleral involvement was seen in 6 of the cases. Primary pathogen could only be detected in 40 of the cases, and rest were microbiologically inconclusive. Now, coming to the distribution of isolated organism in these culture-positive cases, 65% were found to be of fungal origin, most commonly Aspergillus, and 20% bacterial, most commonly Staph aureus, and rest others, 15% were of mixed origin. 10 cases were found to have lens involvement with the primary infection, and removal of lens matter sparing the posterior capsule was done in these cases. In 7 cases, inadvertent removal of lens bag complex occurred, and though anterior vitrectomy was performed in these cases. Coming to the graft clarity, allowing the view of anterior chamber could be maintained only in 26 cases, 15 of which were of bacterial keratitis preoperatively and 5 had fungal pathology preoperatively. Rest 6 of them, the nature of pathogen was not known before the surgery. Now, distribution of organisms in cases of graft infection. Again, the fungus was found to be more predominant, commonly Aspergillus, and bacterial after that, and majority of them were inconclusive microbiologically preoperatively. The earliest onset of infiltrate seen in graft reinfection was 2 days after the surgery. And none of the cases got repeat infection after 3 weeks of surgery. And they were treated with topical and systemic antifungal and antibiotics depending upon the primary pathogen isolated. And in cases where primary pathogen was not known, topical and systemic antibiotics were the main arm of treatment. Now, regarding to maintenance of globe integrity, anatomical restoration could be done in 96% of cases, and 4 cases ultimately required evisceration despite all measures being taken. Now, repeat TPK, 7 out of 23 cases of reinfection required repeat TPK. 10 out of 47 cases of secondary glaucoma required glaucoma surgery, and 4 cases were eviscerated, as I mentioned earlier, of which 3 had pre-operatively scleral involvement at presentation. So the outcomes, what we could come out is the graft infection rate was 23%, and the success rate as related to anatomical restoration and all. Bacterial was, the patients having bacterial infections pre-operatively were found to be 83.34%, and fungal followed by fungal 76%. With regards to globe integrity, 96% of the cases were salvaged. Coming to graft clarity at the end of 1 year was around 26%. What we could see that it was lesser than other studies, and in fungal cases it was 19%, which was again lesser than other studies. Repeat TPK required in our center was a little higher than the other studies shown, could be possibly due to the late referral coming at the center. Glaucoma surgery was required in 21% of post-TPK glaucomas. So to conclude, I would say that the post-operative successful outcome of these cases can be considered in terms of 2 factors. Either you go by the infection eradication and the maintenance of globe integrity, at least so that you can salvage the eye. Initially, if the graft clarity is not to that extent, at least you can salvage the eye for a sight restoring procedure which can be taken up later. So this had been published, and I think the take-home message is try to salvage maximally by doing a TPK, because there are certain bad-looking eyes also. They behave in a better way when you go ahead with the salvaging procedure. Thank you.
Thank you, sir, for the talk. Next, I would like to invite Dr. Amit Raj, sir, for his talk on capsular management in pediatric cataract. Sir heads the Department of Ophthalmology at AIMS Patna.
A very good morning to all of you. At the outset, I am thankful to Boss Executive for making me part of this session. Coming to the topic, pediatric cataract poses a different set of problem. One of the problem is clarity of visual access, and optimal management of capsule is very important, whether it is anterior or posterior. So 2 problem is most important: elasticity of capsule. So that is why chances of peripheral extension or oversizing is very high, and vitreous upthrust, in which basically it should be contracted with high molecular viscoelastic. Staining of capsule is again very important, as it improves the visibility, and in some study it has been found that it decreases the elasticity. Coming to the anterior capsulotomy, although manual capsulorhexis can be done at any age group, but it has been found that one can do after 6 years. One can use bitractor, but it depends on the personal preference. Another important thing is the use of forceps. There is no role of cystitome. One should use either utrata or coaxial microforceps. So one should first, after nicking, one should use the utrata, and then always there should be centripetal force, grasping and regrasping, and always plan for 1 to 2 millimeter shorter axis, so that one can get optimal size axis. Vitrectoraxis can be done in any age group, but mostly it is required in thickened or fibrosed capsule. Sometimes piercing of anterior capsule is very difficult. One can use 260 to pierce the capsule, and then one can use micro scissors to cut the capsule, and accordingly then vitractor can be used to increase the size of the capsulotomy. Multiple nick can be done. Ideally, 3-piece lens should be implanted, but if it is not available, one can implant a single-piece lens in the person. Coming to the posterior capsule management, again, it is very important, especially in younger age group. PCC should be done. So again, after completing the anterior capsulorhexis, one should not overfill, and after nicking the posterior capsule, first inject a small amount of high molecular viscoelastic to separate it from anterior halide, and then one can use utrata or microforceps. It is very thin, so handling is difficult. Again, in some cases, there may be thickened capsule, or even in normal cases, one can go after implanting the IOL, one can use vitractor to clear the posterior capsule. And one should increase the size at least 3.5 to 4 millimeter. Size of the posterior rhexis should be there. There may be sometimes there may be pre-existing defect in the posterior capsule, or maybe due to trauma there may be defect, and in some cases there are few studies in which it has been found that posterior capsular opacification is almost similar if one go for just PCC and posterior optic capture. Yeah, there was a large oval defect, so again anterior vitrectomy was done, and size of the defect was increased so that it should not come into the visual axis. A 3-piece IOL was implanted, and then optic capture, posterior optic capture was done. So to summarize, capsular management in pediatric cataract surgery determines the surgical strategy and site of IOL fixation. Deeper plane of general anesthesia preferable to reduce vitreous subthrust. A stepwise understanding of capsule management results in good surgical outcome. Thank you very much.
Thank you, sir, for the talk. Next, I would like to invite Dr. Salab Sinha, sir, for his talk on managing traumatic cataract. Sir is the director of Nayandeep Netralaya at Muzaffarpur.
Thank you, Shivani, and thank you to the BOS Scientific Committee for including me in this session. छोड़ दीजिए, leave it. So I'm just going to show you 3 videos. So basically, a very straightforward case. Pediatric patient had a history of trauma with a sharp needle. So we should be careful when we dispose of our needles and syringes. So it just went in and punctured the anterior capsule, and very soft lens material, nothing much needed to be done here. Relatively simple case. Just the irrigation aspiration alone is sufficient to remove most of the lens material just by the side port itself. And then you go ahead and put in your, ideally a 3-piece intraocular lens. This is just the loading of the lens. You can see the perforation mark on the cornea. So the slightly trickier than the simple pushing of the intraocular lens. Here you have to rotate it. It's like a screwing action. But a 3-piece lens here goes right into the bag. And then you can make sure that the haptics are placed in the correct orientation and they do not go in the area of the capsular defect. So that is all that is needed to be done here. And of course, you need to suture these cases because they are pediatric patients and you cannot leave them just like that. There's another very neglected patient. He had sustained trauma, probably at that point of time went to various surgeons who decided not to take up the case. But here, you should try and give whatever opportunity for vision to these patients. So using the capsule hooks rather than the iris hooks to dilate the pupil, very fibrotic anterior capsule, trying with all sorts of instruments, forceps, needles, not a very regular rhexis, but still managing to create an opening and using the infusion through the side port, this normal retina infusion cannula. And again, you see the cataract is so soft, it just comes off. There is a small, membrane sticking to the posterior capsule, which needs to be removed also. So you have to remove this, otherwise there's no gain for the patient. Then similarly, putting in the 3-piece intraocular lens and suturing the main wound. Another patient sustained trauma. Again, you can see it's pretty old. The iris is stuck to the wound, so we need to remove that adhesion. Membranous kind of cataract. Create whatever opening is possible. Again, very soft lens matter. You can be removed with the irrigation aspiration alone. But then again, you can see there's a big plaque sitting on the capsule, the posterior capsule, that needs to be removed also. So here, no matter how many attempts I made, I still had to use the cutter finally to remove the membrane. And once again, since these are all planned surgeries, one has to use a 3-piece intraocular lens rather than, again you can see this is a 3-piece lens that goes into the sulcus. So again, suturing the wound, pediatric patient, very important to maintain the integrity of the globe. Thank you.
Thank you, sir, for the talk. Next, I would be presenting on current scenario and management of ROP, a tertiary care perspective. So, India is currently has the highest total number of preterm birth, which is estimated at 30 lakhs, and it accounts for over 20% of all the preterm births worldwide. This is a recent report from Lancet. So coming to the preterm births in Bihar, so it accounts for nearly 16% of all the birth that is happening in Bihar. And the same percentage also contribute to the low birth weight. So we can imagine the burden of preterm birth and low birth weight in Bihar alone. So how is ROP as a problem statement for all of us? So at least 5,000 preterm infants will require ROP treatment every year, and 15% of all the patients who are admitted to the special newborn care units will need screening, and 15% of them will develop sight-threatening ROP. So all these 15% will need urgent laser treatment by the trained ophthalmologist. So we had a CAP study done among the pediatrician regarding ROP. So we had a set of questions, and when we asked about the screening criteria, every 33 of the pediatrician, they followed the standard guidelines. They followed the criteria of gestational age in all the patients, and the birth weight in nearly 75% of the patients, and they took into account other risk factors in approximately 2/3 of the patients. So regarding the timing of the screening, they had the infant got screened at around 30 days of life in 2/3 of the patients, which is the standard criteria. So approximately half of the pediatricians were facing a problem in getting the treatment and screening done for the ROP patients. So the main reason which came out to be the factor in these patients where they generally discharge the patient and then they ask the patient to get reviewed at a ROP screening and treatment center. So why do they do that? Because they told they had an opinion that there is lack of adequately trained or most importantly interested ophthalmologists who are willing to go and screen at their centers. And so all of them, all the pediatricians were aware that ROP is a medical legal liability and it has the highest compensatory loss, which is equally divided between the pediatricians and the ophthalmologists. So how do they share this medical legal liability? So approximately half of the pediatricians told that they took written and informed consent stating that the baby refused screening when they parents refuse to get the ROP screening done in a small baby. So coming to the problem statement in type 1 ROP in Bihar, So this is from a tertiary care perspective of RIO. So none of the inborn patients developed type 1 ROP, and the mean gestational age was approximately 31 weeks, 3 days, and the mean birth weight was approximately 1300 grams. All the patients had history of oxygen supplementation, but the duration and the PO2 and the mode of administration was very difficult to ascertain because they lagged in the RBSK papers and the referrals from the district hospitals. So how was the spread of the type 1 ROP? So basically, most of the patients had stage 3 ROP at presentation, but the alarming presentation was that of aggressive ROP, which was present in 14 eyes in these patients. In fact, stage 5 and stage 4B patients also were considerable, which amounted to approximately 15 eyes in these both the stages. So coming to the aggressive ROP, so the mean birth weight was a little lighter among these patients, amounting to 1,000 grams, with a lower gestational age of around 30 weeks. And the PMA at which they required treatment was approximately 34 to 36 weeks. This was the earliest group to get treated. The main challenge while treating aggressive ROP is the need of long and robust follow-up after intravitreal injections, because it is very difficult to make the patient's attendant understand that they are going to need additional laser in these patients. So all the injections and laser are made free at RIO because it is covered under RBSK under special agreement with State Health Society. So approximately 4 patients needed laser alone, while laser with anti-VEGF was required in rest of the patients. Coming to stage 5 patients, out of 15 eyes that presented, 10 eyes got operated, and most of the patients had presentation at around 8 months. Stage 5 ROP even presented at 2 months of age. Probably these were the cases where the patient had aggressive ROP and the patient failed to get screened at appropriate timing. Coming to the stage 4A ROP, so approximately 34 of the patients got presented at 2 months of post-chronological age. And the mean birth weight was around 1,200 grams, and the gestational age was approximately 29 weeks. And the treatment for which they came was around 40 weeks. So the main treatment modality was laser alone, and in patients, some of the patients needed PPV at further stages, and 4 of the patients got treated with PPV at the first presentation itself. Coming to stage 4B, so one eye had progressed from stage 4A to 4B despite laser. All the 7 eyes underwent vitrectomy, and earliest presentation of stage 4B patients were at 6 weeks. So coming to stage 3 ROP, 44 eyes presented with stage 3 ROP. Only 2 eyes underwent intravitreal anti-VEGF injection, followed by laser photocoagulation after 2 months. And other eyes, they underwent laser photocoagulation at 6 weeks of PCA. And none of the treated eyes with laser progressed to stage 4 or stage 5 ROP. This is very important because this is the stage where we can prevent the blindness in these preterm babies. So to summarize, there is an increasing trend of AROP which we need to keep in mind, and there's a worrying trend of stage 4 and 5 ROP. So, very important is the satisfying anatomical and functional outcomes of treatment in stage 3 ROP. Most importantly, we need to have more trained ophthalmologists to screen in SNCUs at every district. So the ROP management is a multi-folk management. So united we stand and divided we fall is a very this is a principle which applies to ROP as well, where we can have primary prevention, secondary prevention, and tertiary prevention at the level of the pediatrician, gynecologist, and the ophthalmologist. So these babies, they live to see, and let us all help them to achieve the beauty of light and life. Thank you. Next, I invite Dr. Satyaprakash Tiwari, sir, who heads the Vitreoretina department and is the director of Drishtipunj Netralaya, and he is going to present on management of complex retinal detachment. So 30, so less than 30 weeks, they need to be screened at 2 to 3 weeks of age. And more than 30 weeks, less than 34 weeks, it is at 30 days of life. And the cutoff for the birth weight is 2,000 grams. This needs to be followed, and most of the times, the mother doesn't remember the LMP. So we need to look at the birth weight and any other risk factor for which the pediatrician says that the patient needs to be screened even at 36 weeks. The patient needs to be screened for ROP. So this is the criteria for, like, this is the current RBSK guidelines which is being followed. 30 to 34 weeks, 34 to 36 weeks, and less than 30 weeks, we need to screen early because they are going to have more chances of aggressive ROPs because they are going to be lighter babies.
Sir, is that for how long we are going to screen those babies? How long we are going to screen those babies? That is one.
So normal
doubtful area.
vascularization that is happening, the retina is expected to grow temporarily at 40 weeks.
40 weeks, yes.
So we need to screen at least till 40 weeks. If the patient comes and if we are not sure that the 40 weeks the vascularization,
After 40 weeks.
so
is
if the
there any
vascularization
deeper-
is complete,
Yeah.
we need not follow the patient. But if it is the first visit at 40 weeks, we need to have one more visit by the parents. And if the vascularization is not complete, it will depend on the stage at which we are seeing. So it is entirely on the stage. If we are seeing at 40 weeks and the vessels have progressed to zone 3, then we can follow up easily at 4 weeks interval. But if the vessel is still arrested at zone 2, we need to follow up early.
So that means if the vessels are at the equator fully grown up at 40, we need not
Sir, it has to be fully vascularized till zone 3.
till the zone 3.
Ora,
Yeah,
yes.
ora, till the ora.
Yes, sir.
Sir, we have more speakers, sir. Time is very less.
Thank you, sir. Thank you to the BOS Scientific Committee for including me in this session. I am going to speak on complex retinal detachment. So what is REGARDI? It is basically a separation of neurosensory retina from retinal pigment epithelium due to secondary to any breaks, vitreoretinal traction and liquefaction of the vitreous leading to migration of fluid behind the retina. Simple retinal detachments are very easy to manage, and a proper surgery at a time generally restores complete vision to majority of the patients. But many a time due to neglected or delayed diagnosis, patient may develop complex detachment, and generally complex detachment happens in long-standing untreated detachment, detachment secondary to large breaks, multiple breaks, or due to bad trauma, vitreous hemorrhage, choroidal detachment. If there is a large break and PVD, then PVR settles very early and it leads to complex detachment. If a patient redetaches after vitrectomy, that case also progresses very fast, leading to complex detachment and PVR. In modern day, vitrectomy system has improved the outcome even in cases of complex detachment. These are some classifications of PVR and all. This is not important for this session. We would directly proceed to management techniques, and this is a surgery for a complex detachment, simpler among the complex. There is a large superior break leading to a total rhegmatogenous RD with significant PVR. So we have to clear the vitreous properly, and after clearing the vitreous, we have to remove those membranes, and these membranes are generally immature membranes. So generally these membranes are a little bit difficult to remove because it breaks very easily. Whenever we grasp with the forceps, generally it breaks and doesn't come in toto. So we have to put PFCL, stabilize the retina, stain the membranes with dye, and then we can remove all the PVR membrane, or rather do a wide ILM peel, which includes all the membrane as well as PVR changes. And then we can laser all around and settle the retina, putting a silicone oil inside, and can close the case. So another complex detachment we can see, this is 270-degree giant retinal tear, and the retina is torn and completely folded upon the optic nerve. We cannot see the optic nerve in this case, and then initially we clear the vitreous, do the vitrectomy to relieve the tractions, and then we can unfold that folded GRT and reattach those giant tears. Here we are using our vitrectomy cutter as the forceps. We have just switched off the cutting and just use little bit traction and then unfold the retina. This saves time actually. The multifunctionality of these vitrectors advanced machines has saved time a lot, and we are now finishing this vitrectomy and in a very less time. Putting PFCL, settling the retina, then unfolding, rubbing, lifting the edges by this soft tip silicone tip cannulas, and then do laser all around, and then we have to do in these cases direct silicone oil PFCL exchange. If we are going for a fluid air exchange and then we are putting PFCL, putting silicone oil, then sometime there might be slippage of that GRT due to retained fluid seepage. So it is better to do direct PFCL silicone oil exchange, or if we are going to do that FAE, then we have to dry the retina completely and then inject silicone oil. So again, this is a case of horseshoe tear, large horseshoe tear at the macula. So there was a large tear over the macula, and it was an old detachment, and that leads to temporal detachment actually. And in this case, vitrectomy was done, vitreous was stained with triamcinolone acetonide, it was removed, and then we did ILM peeling. But since the edges of the hole was very ragged and it was large, it was not possible to close the hole with just ILM peeling or inverted flap. So we decided to do a retinal autograft technique. So we harvested a part of the retina from the superonasal portion of the attached retina. And actually harvesting a graft from attached retina is a little bit difficult, but in this case we did laser all around to a piece of the retina, and then we cut it with the diathermy, and then we took out that part of the graft and placed it on the macula, and that fantastically got attached there. And even after SOR, the retina was fantastically attached, and we got away with a good attached retina without lasering that macula. Otherwise, we had to do laser over the macula, and that would actually destroy the functional part of the retina, and that is not a very good technique to settle these cases. So these cases also have saved a lot of eyes in which initially we used to, during our training time, there were very less reported cases of retinal autograft. So our teachers used to do laser around the macula. If it is a bad tear, large tear, to settle the retina, they used to do laser. But now these techniques, or sometime amniotic membrane graft, also leads to fantastic settlement in such cases of large macular tears. This is all about my presentation, and we can see that even with a good effort, such complex cases can also be taken care. And this patient was one-eyed patient and just perception of light vision. And after a long operating time, we could settle some reasonable part of the retina, leading to useful vision for that patient. Thank you so much for all your attention. Thank you, sir.
Yes. This autograft is a very interesting thing, but what is the ultimate visual outcome with these autografts?
That patients are surprisingly improved to 6/18. Generally, we do not expect more than 660, 636 vision, but after silicone oil removal and cataract surgery, that patient improved to 6/18 vision. That was very surprising. Even we do not expect such kind of vision in such cases, but sometimes we do get good vision.
Thank you, sir, for the talk.
The tear was at the edge of the fovea, that is why.
Yes, sir. Yes.
Next, I invite Dr. Prateek Nishant, who is Assistant Professor at AIOS for his talk on new outlook on hypertensive retinopathy.
Thank you, esteemed chair, ladies and gentlemen. A new outlook on hypertensive retinopathy. No relevant financial disclosures. So hypertensive retinopathy is known to progress through distinct stages, more or less. The vasoconstrictive, sclerotic, and exudative phases are associated with no complications, but then when the complications ensue, they include retinal edema, subretinal fluid accumulation, and neovascularization. However, neovascularization currently is not included in the spectrum of hypertensive retinopathy. Although initially it was described in 1987, it was later included in a review article in 2016, and subsequently it became known that any neovascularization must be considered a part of hypertensive retinopathy after thorough evaluation excludes other causes of proliferative retinopathy. Still, this neovascularization is not included in any grading or classification system for hypertensive retinopathy. NVN hypertension is the result of ischemia and microvascular occlusions, which may or may not coexist with clinically obvious retinal vascular occlusions. Arterial sclerosis in hypertensive retinopathy is basically mid-peripheral, and so occult peripheral arteriolar occlusion or tributary venous occlusion of the retina must be considered whenever neovascularization is encountered, even without obvious retinal vascular occlusions. Various pathophysiologic, clinical, and epidemiological studies have been done, which confirms the role of hypertension being in close relationship with retinal vascular occlusions, to the extent that about half of all RVOs are attributable to uncontrolled hypertension. RVOs also subject the affected eyes to additional interventions like laser photocoagulation, anti-VEGF agents, and the risk of complications related to these procedures or progression of the neovascularization. NVG and tractional detachment are the dreaded sight-threatening complications. Literature has demonstrated some of the cases which have neovascularization in the setting of hypertension, in which hypertension alone has been attributed as the cause of the neovascularization. Brancato et al. Reported the first case in 1987 in the case of toxemia of pregnancy, wherein DIC was the incrementing factor. However, accelerated hypertension induced fibrinoid necrosis and consequent occlusion of peripheral retinal arterioles appeared to be the major pathophysiologic factor in that case. Georgiadis showed macular ischemia, peripheral retinal ischemia, and neovascularization with vascular leakage in a case of extended occlusive vasculopathy of unknown cause, which was later revealed to be malignant hypertension. Abbasi et al. Showed a case of severe hypertension with systemic complications. Golshali and Vila reported a case of hypertension secondary to IgA nephropathy, wherein the diagnosis of massive retinal and choroidal infarction was made with NVG and TRD. Stryjewski demonstrated a case of vitreous hemorrhage, FVP, TRD, and neovascularization. Speed has shown a case of bilateral neovascularization and vitreous hemorrhage. Although the patient had vasculitic risk factors, the authors concluded that retinal findings were attributable to hypertension alone. This case also landed up with extrafoveal tractional membranes. Jung and Ameri also showed CNP and neovascularization, and the left eye had clinically obvious neovascularization, angiographically diagnosed to be due to superior nasal BRVO. This case showed that the FFA alone may reveal an RVO even if it is not clinical obvious. And this case also shows that multiple interventions may be required in patients with RVO and NV in hypertensive retinopathy. Based on all the literature, Mishra and et al. Have recently concluded that current classification systems do not provide adequate coverage to malignant hypertensive changes. They demonstrated a fundus picture of one of their patients with superotemporal BRVO along with possible cilioretinal artery occlusions with inferior subretinal fibrinous exudation due to associated choroidopathy. In our experience, we did a survey of 40 cases in which 10 eyes of 9 patients presented with retinal vascular occlusions. The high rate of retinal vascular occlusion is consistent with other studies. And it is not necessary that this is associated with hypertensive crisis alone. Stage 1 hypertension and stage 2 also showed retinal vascular occlusions. This is one demonstrative case which presented with old bilateral STBRVO and NVD and NVE, which were subjected to anti-VEGF injections and photocoagulation. The significance and clinical application of this discussion is that whenever we encountered these kinds of eyes, we must consider that these eyes already have ischemic and long-term damage by occult, if not obvious, vascular occlusions. The RVOs may not be so obvious, so we might consider FFA, especially wide-field FFA if available. In our experience, hard exudates and macular starts are not demonstrated with FFAs, but non-perfusion leakage, macroaneurysms, and shunt vessels are well demonstrated. So the new outlook now includes addressing the chronic global ischemia associated with hypertensive retinopathy, considering the risk of neovascular proliferation even without clinically obvious RVOs. The new outlook now also includes to differentiate the retinal vascular occlusions found in a background of hypertensive retinopathy changes from the RVOs occurring in the absence of hypertensive retinopathy changes. And we might even make an overarching claim of proposing a new classification system of hypertensive retinopathy, including retinal vascular occlusions in the background of hypertensive fundus. Thank you.
Thank you, Dr. Pratik. Next, I would like to invite Dr. Asif Sir, who is HOD of Darbhanga Medical College and Hospital, for his talk on comparison of dichoptic versus orthoptic in treatment of anisometropic amblyopia in children.
Good afternoon, the chairpersons. Good afternoon, all the chairpersons and the learned audience. I am thankful to Scientific Committee of BOS and AIOS to giving me the opportunity to present over here. My topic of presentation is comparison of orthoptic versus dichoptic therapy in treatment of anisometropic amblyopia in children from 6 to 12 years. I have no financial interest in any of the product used in the study. Amblyopia is defined as unilateral or bilateral reduction in best corrected visual acuity caused to form visual deprivation and abnormal binocular interaction without a visible organic lesion commensurate with the visual loss. Apart from decreased visual acuity, it also results in reduced contrast sensitivity, abnormal spatial distortion, and inaccurate monocular fixation. Recently, there has been a major shift in the understanding of amblyopia, where the older monocular disorder view has evolved to be a binocular disorder view. Recent researchers focus that mechanism behind amblyopia involves primary abnormality occurring in the visual cortex area V1, further disrupting the higher order areas involving depth perception. It suggested that it is not just a problem of eye, but also a neural deficit with potential for plasticity even beyond the critical period of visual development. Now, what is dichoptic therapy? Dichoptic therapy works on principle of binocular balancing. Simultaneous and different visual stimuli for each eye are given, where contrast to a stronger eye is reduced to balance. It blurs the central vision of the fellow eye. Both the eyes work together to control the image contrast given by specially designed video games on a smartphone while wearing special anaglyph glasses. It improves visual acuity, enhances contrast sensitivity, and improves stereopsis. Orthoptic is non-invasive device that target to stimulate the magnocellular and parvocellular pathway. The parvocellular cells end in primary visual cortex at the level of 4C beta, and magnocellular cells end in V1 at the level of 4C alpha. The machine has 3 rows of light emitting diodes, of which the central one is red and others are white. The patient is made to sit at 1 meter distance from the device wearing the correction glass or contact lens, ensuring the red light is at the eye level with the patient's eyes in the primary gaze. The patient is instructed to point at the light using a laser pointer that comes up on the screen in random sequence. Each time the light is on for 300 to 500 milliseconds on the screen. This procedure is first done with the good eye patch for 20 minutes, then repeated with good eye open and amblyopic eye patch for 5 minutes, and finally with both eyes open for 5 minutes. So one session consists of 30 minutes. Secondly, the patient is instructed to focus on the central red light without changing gaze. Count the peripheral lights that switch on for about 300 times. This part of exercise stimulates the covert attention, which in turn stimulates the lateral occipital region. This constitutes one session of therapy. My aim of this study is a comparison of orthoptic versus dichoptic therapy in treatment of anisometropic amblyopia in children. A prospective randomized study was conducted at a tertiary eye hospital. A total sample size of 40 children aged from 6 to 18 years with anisometropic amblyopia attending the outpatient department of DMCH was taken. They were assessed for visual acuity, cyclopelagic refraction, contrast sensitivity, and astereopsis. 20 children were advised for dioptic therapy through video games on a smartphone using anaglyph glasses for 2 hours per day for 6 days in a week in Group A. 20 children of Group B underwent 10 sessions of orthoptic treatment with each session of 60 minutes. Both groups were evaluated after 6 months. Total 40 patients of anastomotic amblyopia was taken. Mean age of Group A was 8.75 years and of Group B was 9 years. There was total 23 females and 17 males. At the end of treatment, visual acuity improved in 70% in Group A and 90% in Group B. Astereopsis improved in 60% in Group A and 85% in Group B. Binocular single vision improved in 75% in Group A and 95% in Group B. Conventionally, amblyopia has been treated using patching or optical or pharmacological penalization using 1% atropine, stimulating visual development in affected eye. These worked by forcing the fovea to fixate, stimulating of bottom-up impulses to overcome the suppression. As amblyopia is now understood to be binocular disorder, need for new treatment modalities. Dioptic therapy primarily works by presenting different stimuli to each eye, integrating them for binocular viewing. This therapy can be given at home but may be associated with asthenospatia, attention deficit, and require adult supervision. Orthoptic focuses on cortical stimulation. It stimulates the attention area in parietal cortex. Our study focused on comparison in these two modalities. I have to conclude by conclusion is orthoptic is a safe, non-invasive and less time-consuming treatment option, causing more improvement in astereopsis and binocular vision compared to conventional method, hence enhancing the quality of vision. Further validation are needed, but its emerging role cannot be ignored. Thank you for listening here.
Thank you, sir. Next, I would like to invite Dr. Pooja Sinha ma'am for her talk on fever and retinitis, a diagnostic dilemma. She is the director at ABI Hospital and heads the VR department there. Dr. Pooja.
A very good afternoon. I'm thankful to Bihar Ophthalmic Society for this opportunity. I'll be presenting a very interesting case which I recently encountered, a curious case of fever and retinitis. So this was a 24-year-old male patient who complained of diminution of vision in both eyes, left eye more than right eye of 15 days duration. He had a history of fever with severe headache 1 month ago. So on examination, vision in the right eye was 6/6, but in the left eye was markedly diminished to counting finger of half meter. So this was the fundus picture of both eyes. There were multiple cotton wool spots which were sitting in the peripapillary area and the papillomacular bundle, and in the left eye they were also along the superior arcade. So this was the OCT picture which showed retinal thickening along with the intraretinal edema and cystic spaces, along with a lot of hyperreflective dots suggesting inflammation. And this was the left eye. There was a marked retinal thickening along with intraretinal and subretinal fluid. So this was the FFA picture which showed lacy hyperfluorescence along the optic disc and the superior arcade. On investigations, his BP and random blood sugar was normal. The Vidal test showed Salmonella typhi A as reactive, and the rest of the investigations were negative, non-reactive. So I made a diagnosis of post-fever retinitis secondary to typhoid fever. The patient was started on systemic steroids, starting with 50 milligram per day in weekly tapering doses. Along with that, I added oral ciprofloxacin 500 milligram BD for 5 days. So after 5 days, the vision in the right eye was 6/18, and the left eye was only marginally improved to counting finger of 4 meters. So this was the picture after 15 days of systemic steroids. The cotton wool spots such as retinitis lesions in the peripapillary area with a macular fan in the left eye, suggesting a resolving macular edema. And you can see on the corresponding OCT There was thickening of the inner retina and after shadowing and minimal subretinal fluid in the right eye. And this was the picture in the left eye. This was the subsequent FFA, which showed a lot of capillary non-perfusion areas along with hypofluorescent patches. So because there was non-perfusion and ischemia, I added injection ranibizumab in the left eye, followed by right eye after a week. And this is after 15 days of injection in the left eye. You can see that the edema is coming down and the cotton wool spots also had decreased. And this was the picture in the right eye. And this is both eyes together. So you can see that the foveal contour is slowly getting retained and the fluid has decreased. And this is also of the left eye. You can see that post-injection in the bottom picture, the fluid has resolved and the edema has also decreased. So this is the OCTA which I had done. So in discussion, a post-fever retinitis is an infectious or para-infectious uveitic entity caused by bacterial or viral agents. It usually occurs in the 3rd week after onset of typhoid fever. This is referred to as the week of complications. Typhoid retinitis may occur secondary to direct invasion of S. typhi bacillus, or it could be an immune-mediated reaction. In most cases, fundus lesions resolve, leaving pigment epithelial changes and foveal thinning. Though there was no endophthalmitis secondary to typhoid in my case, the vision was very poor. This was owing probably to retinitis lesions sitting directly on the papillomacular bundle. Thank you so much for your kind attention.
Thank you, ma'am. Next, I would like to invite Dr. Nilesh for his talk on financial aspirations of young ophthalmologist entrepreneur. So he is at Madhvi Netralaya at ARA.
Thank you so much, ma'am, and thank you, BOS Scientific Committee and BOS leadership for providing me this opportunity. I'll be very quick as we are over the time. So, I'll start with what aspiration we have. When we go into the trade, we see a lot of fancy instruments, and the aspiration is to have all of them. Everybody thinks that they should have all the toys to play with, but we have to divide it into some must-have or essential equipments, should have or optional equipments, and then can have or desirable equipments. So the must-have for an OPD is an autoref, a tonometer, optometry setup, a chair unit, slit lamp with 3-step or 5-step with imaging, and indirect ophthalmoscope, and all of the fundus lenses. So this basic setup will set you back by around 8 to 10 lakh rupees. And you have a OT setup that requires an autoclave, ultrasound biometer, a good quality microscope, a surgical recording system, a basic phacoemulsification system, which is right now very costly, and ND laser. So all these will set you back by around 20 to 25 lakh rupees. So what are the options and why we need to know about finance? Because you need capital around 30 lakhs to start your private practice. You need to have your tax planning done, and you have to leverage your balance sheet. So that's why you need to know your finance. So a very famous example is Vasan Eye Care. This was an example given in India Today magazine, where they told that Vasan has too little batter and they spread the dosa too much, so the dosa broke. But the opposite can also be true, where you have a dosa batter and you are not spreading and you are not having a dosa. It's an uttapam that you will have. So you have to have a right balance to stretch and you get a good crispy dosa. So you have to understand how much you want to leverage. And optimal leverage will give you a good profit margin. And over leverage, you earn more, but your profit margin decreases. And when you under leverage, when you don't use your capital and your debt in a very good way, you have a large profit margin, but you can see the amount of revenue that you generate is very less. So finding an optimal leverage is very important. And the options of funding include inheritance, internal accrual, borrowing from friends, families, relatives, interest-free loan, IOL bundling with premium, without premium, loans from national banks, and loan from NBFC. And why me? Because I have right now everything going for me. Inheritance from my father, internal accrual through residency and through the salary that I earned before joining him. Borrowing from family, nobody gave me, apart from my father. Interest-free loan or equally divided PDCs for a specular microscope that I have got. IOL bundling without premium for Callisto is going on. IOL bundling with premium is going for Quatra. Loans from not from nationalized bank but from NPFC for Claris and Cirrus. So internal accrual is the best method through all of these that I have figured out, is because when you are going to pay an EMI and you do an SIP for the same amount, you see from having to pay an EMI of 20,000 and do a SIP of 13,000, 7,000 per month saving, and you are getting more on the average. So that's the concept of reverse EMI. Even if you inflation adjust for inflation, you are going to save a lot of money if you are going for internal accrual rather than going for anything else. But we won't have that much amount, and we don't want to wait for so much. We have to wait for 10 years to get the internal accrual. In that scenario, what we can do is do a lump sum payment upfront. And some amount we can go for a deferred payment or post checks through 1 year. So this we can do for any instrument that is going to cost us below some. We have to see how much our cash flow is, and this option can be taken up to machines which are around 10 to 20% of our total cash flow in our hospital. More than 20% of our revenue, if the machine is costing, better to go for a loan and an EMI. This all is very calculated based on different machines, but it will require too much of time to go through. IOL bundling is to be done in the scenario where the machine is directly related to the procedure that you are doing. So if you are doing cataract, then it's better to bundle your microscope or your phacoemulsification system with that. If you are not, it should not be done for the machines that are not generating revenue directly for IOL. And considering with premium and without premium, always go without premium, because with premium it's nothing. You are tied up with that company for paying for using the IOL also, and you are paying the entire amount yourself. So better to go for IOL bundling without premium than going for with premium. The amount will become less. And also, the IOL market price before negotiating. Get the best price for your equipment beforehand, before negotiating the deal. Try to diversify a strategy in high-cost equipment, so you break it into lump sum, PDC, and bundling all three. Confirm whether the ownership will be transferred initially or at the end of the tenure, because if it is going to be at the end of the tenure, you are going to have a second-hand machine with no depreciation benefit, and that implies on your tax. And try to keep the volume calculation on annual basis at negotiation. So how to decide? Internal accrual is the best way. For equipment costing less than of your 20% of your annual profit, have a lump sum. From 20 to 50% of your annual profit, have it on PDC. Equipment costing 50% of your annual profits, lump sum with PDC. And more than 50% of your annual profit, get it financed. So that is how what my take is till now. Thank you so much.
Thank you, Dr. Nilesh, for the wonderful presentation. And next, I invite Dr. Vibhuti, sir, for his talk on 10 dictums in glaucoma diagnosis and management. Sir is HOD of RIO IGMS, which is a state-of-art facility, and heads the glaucoma services there.
In our 20 years of practice, we have never thought like this. So wonderful to have this. We are short of time. यार ओपन नहीं हो रहा. Open it. So I'll be talking in very short on 10 dictums which I follow while evaluating the cases of glaucoma. No financial interest. So first one is opportunistic screening. One should do. Whenever we get a chance, we must do the opportunistic screening to find out any glaucoma suspicious patient. Why? Because we know that with increasing age, glaucoma is more, and around 40 to 60% of patients are still undiagnosed. So we must use our tools to, in the best way, to detect those cases. We know that 97% of sensitivity is at risk group using basic visual tools. That was the finding of Zhao et al. In 2017. So if you use your tools correctly in the correct patients, in the correct high-risk patients, then there are more chances that you may land up in diagnosing more glaucoma cases. Number 2 is gonioscopy is a must. More and more cases are there of primary angle closure disease. PACG leads to more blindness, and that's why gonioscopy need to be performed even at the primary diagnosis and then also in consequential follow-up of the patients. So PACG is more visually devastating, high prevalence in Asian females, hyperopes, preventable with early intervention. So we shouldn't forget and we shouldn't allow gonioscopy to be done always. Then field analysis is another important thing. Must do at least 4 to 5 visual field in the first 2 years to find out the baseline as well as the trend of the glaucoma. That is only going to decide upon your treatment profile, whether you need to be aggressive, whether you need to be a moderate in your approaches. So change in the mean deviation of more than 1 decibel per year may significantly decide that the patient is progressive. The fourth one is structure meet function. So dual lens approach, we have to correlate between the structure and the functions, and establishing a correlation between these two parameters is critical for diagnosing, monitoring progression and tailoring the therapy. These are the tools which are available for the evaluation. OCT is right now available everywhere. We can utilize the RNFL thickness and the GCC complex for better structural assessment. And then we have to use the tools like HFA or FDT perimetry for functional assessment. Now correlation becomes more obvious in the early stages. Structural damage often precedes the visual loss. So you'll see some changes in the structure, but you won't find more in the visual field. In the moderate glaucoma, correlation is more or less equal, but in advanced glaucoma, again OCT goes to the floor effect and we don't find any changes, but the visual field goes on changing its paradigm. So the treatment, the guideline is both OCT and SAP should be done at the baseline periodically. Trend need to be seen rather than see the printout in isolation. 5 to 6 reliable field has to be done to find out those things. Then foundation of effective medical management in glaucoma is the medications, and these medications we must remember the mechanism of action and we must employ in a judicious way to optimize the treatment protocol. So drug selection activity like patient factors, target, age, comorbidities, characteristic efficacies, drug rotation has to be done. Then other thing is that fixed drug combinations are now available which can give you leverage in giving maximal medical therapy and still preserving the patient lifestyle. Generic medications can also be utilized in Indian scenario to minimize the cost. Laser procedures need to be placed at appropriate place, then only it is going to help you. Like in cases of SLT, if you give it in the early stages of treatment, the patient might have few years of glaucoma-free medication therapy. Then there are other like micropulse therapy, cyclophotocoagulation, they have to be employed at a proper place. The timely surgical intervention is again very important factor. Medical therapy or laser therapy fails, then we have to do progressive optic nerve damage which is not being controlled with the medications, patient adherence is poor or acute angle closure crisis or congenital or secondary glaucoma. So the timing of surgical intervention is very important, but one thing is very sure that congenital glaucoma we have to do surgery. In cases of neovascular glaucoma we have to, or in the cases of secondary glaucoma we must treat the primary cause also, and in the other cases like primary open angle glaucoma we have to employ our medical therapy first, lasers also, and if it all fails then we have to naturally proceed for the surgical therapy. And these MIGS are changing the paradigm of the glaucoma therapy right now. So at least one should learn one of the procedure like bang to associate it with the phacoemulsification or even in the primary therapy to add to the glaucoma treatment paradigm. And then finally, we have to also keep in mind the 8th one is the managing systemic comorbidities. We must not follow we must follow these advices like the patient nocturnal BP has to be evaluated. Why the patient is progressing, that need to be coordinated and correlated with what is happening with the patient normal systemic diseases. And follow-up is very important. So lack of follow-up is one of the strongest predictor of the glaucoma-related blindness. We must devise a protocol for each of the patients for seeing what has to be done. Just a minute. Then glaucoma status has to be done, recommended follow-up has to be given, and tool that aids our GPA has to be done, OCT trend analysis should be done. And in the first 2 years, the glaucoma, we must identify those progressions also. And finally, one has to do a good conversation with the patient regarding the glaucoma itself to motivate the patient to have a lifetime therapy for glaucoma in order to prevent these preventable blindness. Thank you very much.
Thank you, Professor. ये नहीं चल रहा है क्या? A big thanks to all the speakers. I would like to request everybody to please come on the stage for a group photograph. All the speakers, please, and the chairpersons. I'd like to thank Dr. Shivani Sinha for moderating this session of Bihar Ophthalmological Society so well, and all the speakers for making some amazing presentations. कहीं पीछे आ जाइए, पीछे आ जाइए. अच्छा आगे आ जाइए, आगे आ जाइए.